start. Okay. Well, good afternoon. We're back again to talk about respiratory emergencies in children. And again, I have no relevant conflicts of interest, and none of the equipment that I'm going to show you is intended to endorse any particular type or brand of equipment, but just to show you examples. What I thought we'd do today is to think a little bit practically, but also theoretically, about respiratory emergencies in children. When we look at this child, which is just a still photo, we can instantly, from across the room, understand that this child is upset, is likely to have some respiratory distress. We can see the features of the child that are different from the adult. We can see the relatively large head. We can see the inability to communicate what's bothering them. They can't tell you what's wrong, that they're having pain, or that they're having difficulty breathing, or that they're wheezing. You have to find that out for yourself. We can see the very small and soft chest of the child with the ability to have retractions almost down to the backbone. And we can see the relatively large stomach with a very lower esophageal sphincter tone that allows air to fill the belly very easily. In a few minutes, we're going to be seeing the inside of the airway of the child, and you'll hopefully, if the videos work. My wife is a pediatric otorhinolaryngologist, and so she does endoscopy quite frequently. And she lent us some photos of children with, some videos of children with normal and abnormal anatomy and physiology that we might be able to see. But you can see from here that the way we manage an adult is going to be different from the way we recognize and manage a child. One of the most important differences I want you to think about is the reserve. How much muscle does this child have? Not too much, so that they can become very weak and floppy. They can sustain themselves and then become weak, lethargic, floppy. And also, the lungs underneath this soft chest. One of the problems we have in children is that the functional residual capacity, the expansion of the lungs at rest, is very close to what we call the closing capacity of the small airways. So the adults have a larger amount of reserve before their small airways start to collapse on exhalation. Babies, that normal tidal ventilation, then they have a reserve volume, and they have this functional residual capacity that is very close to where their small airways close. And so, even if we pre-oxygenate them, if we give them a lot of oxygen, they desaturate very quickly compared to adults. So, think with me for a moment. You're on call tonight. You're presented with a 12-month-old child who seems to have bronchiolitis, tachypnea with a respiratory rate of 60, some respiratory distress with retractions and nasal flaring. The test for RSV is positive. The test for COVID is negative. And he has worsening symptoms over the last 12 hours that seem to be accelerating, and you're quite worried. This child is heading towards respiratory failure. When you enter the room, the infant is grunting, not gasping, but grunting on each breath, trying to give himself or herself PEEP with every breath, trying to hold the lungs open. The pulse oximetry on the finger is reading 80% on a simple face mask oxygen at 10 liters per minute, and his respiratory rate starts to slow down, and his effort starts to get less, and he starts to get lethargic and sleepy. At first, you think it's a good sign that his respiratory rate is slowing down, but you realize he's tiring out, and so it's not a good sign. So let's think about how we would support this child. This is a respiratory emergency. And what if the saturation continues to fall despite your efforts? What are some of the initial things that you're thinking of that could be done to improve the situation right now? Just call out some suggestions. What do you think?
ventilation.
You could jump right to ventilation, but you want to prepare for that. Maybe he needs that. But what else could we do in the meantime while we're getting ready to open up the bag mask, get the mask? What? What do you think?
Getting in proper position.
A good position for the child? Yes.
Suction the airway.
Yes, we're going to suction his airway, right? And make sure we have the right catheters available. What else? How about the oxygen? Simple face mask, is that the best thing for this child right now? High flow. Could be high flow nasal cannula, but even better maybe a non-rebreathing face mask. You might be thinking he's a young child, so high flow nasal cannula might give him a little peep. Maybe that would be good to keep the airways open. But the best oxygen, the highest concentration of oxygen I can get him with a saturation of 80% is probably a tight-fitting, non-rebreathing face mask with a nice reservoir as I'm preparing the bag mask ventilation for him. What else would we be thinking of? We have suction, we've thought about oxygen. What component of this is lower airway and upper airway? What do you want to say?
Maybe also
what? I'm sorry, fluids. So getting IV access, starting some fluids because he's been breathing very fast for a long period of time. And also in an emergency, we want to have an IV in, so that's good. So, pediatric respiratory emergencies. How are children different? If we think, who's doing anesthesia? Anybody? Yes, a few people. So why is it that the anesthesiologists, when they have a normal adult, they pre-oxygenate them, then they go prepare they prepare their IV, they get some succinylcholine, they get some, and even if the patient is apneic, for 8 minutes, they stay well saturated if they're normal, healthy adults. But if you take a critically ill adult, you guys know, right? And they don't have as much lung reserve, their FRC is worse, they desaturate in 5 minutes. But look at the normal 1-year-old, a normal, healthy 1-year-old, pre-oxygenation for 8 minutes with high 100% oxygen, they'll desaturate after 4 minutes. And the critically ill infant, in 1 minute or less. They have very little reserve. This is old data, 1997 from the textbooks. It's not new. But we have to remember, this is why when we're intubating, when we're providing respiratory support for a young child, we oftentimes can't do a standard rapid sequence intubation like you would in an adult. Because they desaturate, we oftentimes have to bag mask in addition to giving medication. What is special about children? In the newborn, a lot of times, all they need is stimulation to cry, to open up, to take the liquid out of the lungs, and to get air in. About 3 to 6% of babies around the world require some basic resuscitation. And only a very, very small percent need more than effective ventilation. What's different about children than adults? In a normal adult airway, 8 millimeters, right? We usually use a 7 or an 8 tube. The swelling, if you have airway edema, inflammation, croup, whatever, it only reduces the internal diameter by a little bit. But in an infant who's starting with a 4 millimeter airway, if you get the same amount of edema, it shrinks the diameter quite a bit. And remember that the resistance is related to the 4th power of the radius of the circle. So if we have a narrowing, we have to the 4th power increase in resistance. And that's why we have problems with small airways. In children also, the airway narrows beneath the vocal cords. And so in adults, if you get the tube, between the cords, it's generally the same diameter all the way down. But in the children and infants in particular, when you get beneath the cords, the airway continues to narrow. And so you can have what we sort of a subglottic, beneath the glottis, narrowing, a difference. And also the airway is higher up in the child. So the children and infants, their breathing is more anterior compared to the esophagus. Why is that good? If any of you have babies, children, I think you do, yes? 1 year old? 1 year, 2 months? Yes. They can drink and breathe at the same time. It's amazing. Is it amazing? They don't joke. They just drink and breathe constantly because the airway is very anterior. They have a big floppy epiglottis and they have gutters down the side that go to the esophagus. It makes it very easy to intubate the esophagus in a baby, but it also is very efficient for breathing and eating at the same time, drinking milk at the same time. So it's a different anatomy, and it means, those of you in anesthesia know that oftentimes in an adult, to intubate a patient, we put a shoulder roll under their shoulders, back here. But because of the big head of the children, oftentimes of the infants and children, to get the airway straight, we oftentimes put a pad under the head and tilt it back into the sniffing position. So a difference in children. What is the reason we have respiratory failure? On the left, oftentimes the babies don't take a first breath of life. We have to stimulate them. We have to intubate them when they have meconium. Or a little later on, they have apnea of prematurity. And so they need help breathing for that reason. Some infants have congenital heart disease or other chronic problems that require assistance with ventilation. And as they get older and older, the airways get bigger and bigger, and they have less frequent problems with respiratory failure. The adolescents more frequently with heart-related issues, commotio cordis, injuries, trauma, and self-inflicted injuries. Vascular access is different in children than adults. It's much more difficult to get IV access in infants and kids, and we oftentimes need to go to an intraosseous needle in an emergency situation. But let's pause here, and Jacopo, I may need help if I have trouble getting onto this other PowerPoint, but we'll see. How's that? Okay. Hello, how are you? No worries, no worries. So, what I'd like to show you, my wife, Ellen Deutsch, she wanted to show you some of the airway anatomy from the inside, rather than from the outside. And so, let's think of an x-ray, a lateral neck x-ray. What are the key landmarks that we think about in the airway that are critical to manage? We have the epiglottis. Here's a view on an x-ray. Of course, an epiglottitis or an inflamed, or that's an airway emergency. That's something that we call anesthesia for. That's something we don't see very frequently anymore, the Haemophilus influenza vaccine, etc. And it frequently is very position dependent. That if you have an inflamed epiglottis or supraglottic area, by sitting up and leaning forward, not leaning back, by not putting anything in the back of the throat to irritate it and send it into laryngospasm, we do a lot better. We have the vallecula, which is right around the epiglottis. We have here, you can almost see the vocal cords. That's the level of the vocal cords. There's the supraglottic trachea. That in infants and children is the area that gets narrowed in croup. And the trachea itself. Here it is in a cartoon. On the left-hand side, your pediatric airway. You can see anterior to the esophagus. You can see it's higher up than the adult. And you can see that it gets narrow as you go down the airway, whereas the adult stays kind of in a cylinder. Here's what, when you put a laryngoscope in, this is a normal 3-year-old. You can see at the top the epiglottis that has been lifted up to expose beneath it the vocal cords, true and false, and at the bottom the arytenoids. And beneath the airway, down here, is a little slit. It's actually like you'll see, it's just like a little slit that is the opening to the esophagus. This is really what a normal larynx in a 3-day-old looks like. It looks a little different. You see the 3-year-old, how kind of like cartilage, how narrow it is. It's not fleshy. It's not hanging down there. I'm going to give him all the slides, so you'll have all of these slides afterwards.
I do.
If you want. You can have them. But this is what a normal epiglottis looks like. This is why in a newborn or a very young baby, when we use a straight blade to intubate, we oftentimes are not able to lift up enough by going into the vallecula above it. We have to reach down and grab it and actually pull it up to see the vocal cords beneath. Here is a 15-month-old. You see how mature the epiglottis is starting to get. The laryngoscope would go above the epiglottis. Here are the arytenoids. Here are the vocal cords. Here's the airway opening. And the esophagus is right below. Now, it's going to be rare for you to see such a beautiful big picture. It doesn't look quite like this. This is through endoscopy, so it looks quite good and quite big. Here's what it looks like when you put a laryngoscope in. And you are seeing now the tip of the epiglottis. You see here in this 3-week-old, normal. You see here are the arytenoids, here's the airway opening, and this little slit down here is the esophagus. There's a little bit of secretions. The cords are moving a little bit. He's not paralyzed, he's spontaneously breathing through the open vocal cords. It's a pretty normal larynx for a 3-week-old. A little bit large epiglottis. Now, here's a 15-month-old. You see a little bit difference of the epiglottis. You can see the arytenoids very nicely, grade 1 view. You can see the airway right there. And this laryngoscope blade is sweeping the tongue out of the way to give you a nice view of the airway. Here's one where they're struggling a little bit to move the tongue out of the way. There are the teeth going by, the tonsils, and now here is the epiglottis in a 3-year-old. Here are the arytenoids. We're going down into the airway now. We're through the vocal cords, and we can start to see that subglottic area that narrows a little bit but doesn't have abnormal bulges. This is pretty normal for a 3-year-old. Now we're going all the way down the airway to where we see the branching of the bronchi. Here's another one. This is a 1-year-old. Now they're struggling to find the epiglottis. Where is it? Where's the airway? I'm trying to sweep the tongue out. There it is, but it's off center. I didn't position the patient quite well. You can see I kind of lifted it up and twisted it, but oh my gosh, I can see the airway. I have the arytenoids. I can still get a scope through there. I don't know if I would have been able to get a tube in there, but I can get a scope in there. And now I'm going through the vocal cords into the airway, traveling down the airway. And the larynx in this patient was dysphonic. This little thing is a granuloma. This child had a tracheostomy. And so they were ventilating through the tracheostomy while they were scoping from above. They took out the tracheostomy, now they're down below. Now, how about this? This 2-year-old suddenly had respiratory distress, a lot of coughing, and look at the secretions. Look at the pulmonary edema. Watch this. What do you think they did? They suctioned a little bit. Watch this. You'll see that all of a sudden the bubbles go away. What do you think they did? The anesthesiologist gave him some PEEP. It was pulmonary edema fluid that was coming up, and they gave the child some PEEP. The saturation came up, they just push the fluid down deeper into the lungs. But when they actually got down there, here we're getting down through the vocal cords, we're now down at the carina. And when they go into the bronchus, they find a sunflower seed. The child had choked and aspirated on the sunflower seed. They had airway obstruction. They had a lot of inflammation. They had a lot of airway obstruction and pulmonary edema. And even after they took the sunflower seed out in this emergency, they ended up having some ARDS, some residual lung disease, that over a few days improved. How about this child? What I want you to see here, this is what happens if you try to suction or instrument the airway. Did you see that? I'm going to show it. I'm going to try to show it one more time. Let's see if it will go back. Okay, now watch when they put a suction catheter at the vocal cords. Here, they're getting ready to suction. Boom. That is what laryngospasm looks like. You don't like to see that. This child has a tracheostomy as well. No harm came to the child during this video. They had a tracheostomy and they were beneath the vocal cords and they were breathing for the patient. But this is an example for anesthesia. This is an example when you give your paralytic and you go ahead and intubate. You don't wait for the paralytic to take effect. It's quite common for us non-anesthesiologists to think we gave the paralytic, maybe we didn't flush it well, maybe we thought it was on, and we're very anxious to move on with the intubation before we have good intubating conditions. At least in my unit, we get very anxious and we do that quite a lot. So we have to actually look at the clock and we give the rocuronium and we wait 90 seconds. It's a painful 90 seconds before we start to instrument the airway because you may have laryngospasm. This is also quite common after inhaled anesthesia in children when they're emerging in stage 2, that they can have a lot of laryngospasm. Can also happen maybe more frequently with ketamine. So there are some triggers that we think about when we're managing these children to expect and prepare for laryngospasm. And how do we treat the case of laryngospasm that's very severe? Mostly with positive pressure. And if necessary, we may have to give a paralytic, a short-acting paralytic, to break the laryngospasm to allow us to ventilate. And usually after doing that, everything is fine, and we wake up as long as we provide good ventilation during that time. This is what we were playing with in the simulation lab. If you intubate, this is the type of, whoops, let's go back. So this is what the epiglottis will look like if you intubate SimBaby. And they have a little subglottic stenosis because that's how they get the pressure in the lungs, is by tightening and loosening the subglottic pressure. So let's think about a 6-year-old, 25-kilo child who has sepsis syndrome, respiratory distress, borderline hypotension, delayed capillary refill, and this child is evolving, they're getting sicker and sicker, and you determine that they need intubation, that they are a combination of respiratory failure and shock, and to be able to support them, you want to take away their work of breathing, and so you decide to intubate. We generally try to have a system, a checklist, a way of approaching children in order to prepare for intubation. Now, for the pediatricians, this is, I think, very helpful because you're calling anesthesia. And when anesthesia comes, if you have done all of these things, they're going to have a lot easier time in helping you support this child. And maybe by the time they get there, you might not need them anymore, because if you appropriately pay attention to suction, if you provide oxygen and maybe nasal cannula for apneic oxygenation during the intubation at about 15 liters per minute, if you have oral airway, nasal airway, if you have prepared for airway obstruction, maybe an LMA, laryngeal mask airway, and if you have properly tried different positions and made sure that you're in midline, that the table is at the right height, that you have the people around the bedside, that you have checked that you have an IV catheter that is flushing well, patent and working, maybe 2. That you have appropriate protective gear on for the intubating people. That you have thought about the medications you might use, a sedative, maybe a narcotic, maybe a paralytic, at least having one of each of those classes of drugs, oftentimes midazolam, fentanyl, rocuronium, and you have a dose drawn up and ready. Then you can be prepared. Because, yes, anesthesia may say, oh, I don't like that, I want to use propofol. Oh, I don't like that, I want to use ketamine. That's okay. But in an emergency, you'll have one drug that you can use that will work. And you'll be prepared for the worst emergency. And then you can adapt and use the very elegant kinds of adjustments that you might want to for a child. The extras, end-tidal CO2 is often forgotten. That once you intubate, or even while you bag mass ventilate, you can use end-tidal CO2 to determine if there's gas exchange, effective gas exchange, because you're trying to effectively oxygenate, effectively ventilate. And, of course, in this child with sepsis and borderline hypotension, having your vasopressors drawn up, a bolus dose of epinephrine, maybe a mini dose, and having the infusions ready to go. What's one of the most common problems we have with monitoring during the intubation process? Oftentimes, we put a pulse oximeter on, and we put a blood pressure cuff on. And I don't know why, but it always seems to be on the same arm. And so just when we're getting ready to intubate, somebody says, just before we intubate, let's get one more blood pressure. They blow up the blood pressure, and the pulse ox goes away, and everybody panics. If you just make sure that the blood pressure cuff is on the other arm, you can save yourself quite a lot of anxiety, yes? So, here we have a 6-year-old with a sepsis syndrome, ARDS 25 kilos. When we're thinking about this practically, I would think that for suction, we would want to have a stiff or a Yankauer suction catheter that can suction big things out in case he vomits, in case I need to get it out, plus a smaller catheter that I can use to get thin secretions or go through the tube once I get the tube in. Both types I would like to have available, checked, and working. Oxygen. I would want to pre-oxygenate the patient as much as possible. And I personally, it's not required, it's not standard, but I personally usually use nasal cannula on top of bag mask so that when we remove the bag mask and we're using the laryngoscope, we have apneic oxygen going. This is quite common in adults, quite commonly used in adults. It's more recently being used in children not with more intubation success, but with less frequent desaturation during the intubation events, particularly in those that are done emergently. And in the elective ones, oftentimes it's not needed, but in the emergent ones, it's oftentimes quite helpful. The one caveat with that is if you're using the nasal cannula during bag mask ventilation, we oftentimes will go to 2-hand, one person managing the mask, one person doing the bagging, to ensure a tight fit around the tubing of the nasal cannula. If you're an anesthesiologist and you're very used to bag mask ventilation, it's not so difficult. If you're not too used to bag mask ventilation, you can have difficulties and it can leak at that spot. We probably would use a 5.5 cuffed endotracheal tube in my hospital for this child. Anesthesia oftentimes picks a half size smaller because they're generally doing elective surgical cases. Oftentimes in the ICU, a septic patient ARDS, we're expecting that their PEEP and their pressures are going to go up quite high. We want the largest tube in that we can get safely because of the resistance problems of a smaller tube. And we use the cuff to stop the leak if we have to go to high pressures. If we don't need the cuff, we can deflate the cuff and we can have a nice leak around the tube if the patient will tolerate it. So in this specific case, my personal opinion, would be to use a cuff tracheal tube about 5 or 5.5. How deep do we put it in? We can guesstimate. If you're an expert, if you're an anesthesiologist, and you just know the depth, you can watch the cuff go beneath the cords and you're great. If you're inexperienced, you can prepare yourself and say 3 times the size of an appropriate endotracheal tube size, 3 times 5.5, 15, 16.5. About 16.5 centimeters at the teeth. We'll put this beneath the cords into the middle of the trachea. If this was a 3.0 tube in a newborn baby, 3 times 3, 9 centimeters at the gum would be about right. If this was a 4.0 tube in a 1-year-old or 2-year-old child, 3 times 4, 12 centimeters here. Is that perfect? No. It's always going to be adjusted here or there. But when you're not used to intubating, when you get it in, you're so happy, you will put it in about 16 centimeters. And the saturations will not go up because you'll be in the right main stem. And you'll say, oh my God, it must be in the stomach. It's not in the right place. Take it out. And if you just calmly say, how deep is the tube? Let's see, it should be at 12 centimeters. Oh my gosh, it's at 16. Let's pull it back to 12 centimeters. Sats are coming up. Everybody is getting happier. So we just have to think, the reason we're giving you these kind of mnemonics, these kind of guides, is not that they're correct all the time. It's not that they're perfect. It's only to give you the reassurance that I know approximately how deep it should be. I know approximately what size I should use. And you still have to use your judgment. The position, oftentimes a shoulder roll, adjusting the bed height, it's very common that we're trying to intubate like this, or we're reaching up and we can't get a good bed. Make yourself comfortable and you'll do a much better job for the patient. How about the people? Making sure everyone in the room knows what the backup plan is, plan B. Because if I'm intubating, once I'm intubating, I'm concentrating on this. I'm not looking anywhere around the room. I'm blocking everything else out. And so if the patient desaturates, becomes bradycardic, needs other things, I'm going to need to know, everybody's going to need to know what plan B is. Okay, we're going to pull out and we're going to put an LMA in and we're going to bag the patient up and then we're going to try again to intubate. So we need to know what that backup plan is and who will be. If I've tried twice and I can't get the tube in, maybe it's time for me to step away and have somebody else take a try. And the last P, personal protective equipment. I think in the COVID era, we've all gotten very conscious about aerosol generating procedures and to be very careful. So what medications do we think about using? We want to make sure that we've addressed sedation and analgesia, whether we want an anticholinergic or just to have it available or to use it, and the paralytic agent, whether we need succinylcholine or a very fast-acting drug, or in a child, because of the risk of hyperkalemia, etc., whether we want to use a slightly slower onset of paralysis with a longer duration. So we want to consider the onset, the duration, the reversibility, whether it induces hypotension, and the availability. For a sick child, and sometimes we'll pick fentanyl as my drug because it's oftentimes very well tolerated hemodynamically, and it's reversible. Whereas midazolam, oftentimes once you give it, it's very difficult to take it away. But it does make the patient forget, and it's a nice sedative if you need it. But ketamine may keep the blood pressure up even better, but may not have quite as much of a sedative effect, and it may cause a lot of secretions. There's no perfect drug. There's no perfect drug. But if I have a few drugs that I know and I can use, then I feel much more comfortable. So, for me, this is not what you should do. This is for me. In this patient who was 25 kilos, who was 6 years old, who had sepsis and ARDS, I would probably have selected ketamine, 1 to 2 milligrams per kilogram, as my primary drug for the induction. I would have considered fentanyl. I probably would not have used midazolam. I would not have used etomidate. This is a drug that's available in the United States that suppresses your adrenal gland. So in sepsis, we wouldn't use it. Propofol is generally used by our anesthesiologist. It probably would vasodilate. It probably would add to the hypotension. In some hands, people would use that with phenylephrine. But for me, I would probably go with ketamine. And some people would use dexmedetomidine. But it has a very light effect. It's not a deep anesthetic for induction. I probably would not use an anticholinergic in this patient who's 6 years old. I would have it available. Dose, I would, if I had it, would be 0.02 milligram per kilogram. And a paralytic, I probably would use rocuronium. 1.2 milligram per kilogram is the usual dose. I find that a little bit hard to calculate in an emergency, so I use about 1 milligram per kilogram. About. I would have considered succinylcholine, but in our unit, we don't use too much succinylcholine. It has to be refrigerated. And because we don't use it very much, we're not very familiar with it. I'm much more familiar with rocuronium, so I use that as my primary drug. There are other drugs that we could use, but that's a little bit beyond this talk. And then I would make sure that we had end-tidal CO2 for this child for sure. I would have low-dose epinephrine, 1 to 2 mics per kilo available to push, and the code dose. I would have an IV with fluids that are running and the ability to give boluses. And I would make sure that my monitors were on with my blood pressure cuff on the other side of the. And in fact, if I had time, I might put an arterial line in this patient so I could continuously monitor their blood pressure while intubating. Don't forget PPE. So I think, Jacopo, I'm going to stop there. We have some other examples if we want to talk about them, but we have until, what, just a few more minutes, 5 more minutes? 20 minutes. We still have 20 minutes. Okay, good. So why don't I stop talking there? Why don't we see if there are questions maybe about this case, maybe you have some comments on the case, and we can see if you want to talk about other types of respiratory emergencies. What do you think?
I have only something to tell you.
This is the live mic, yes?
May I? How to okay. Sorry. I'm Lola Miali. I am an Italian Canadian pediatrician, and I'm here to assist and to listen, to learn so much from you and stay with you. I would like to make something like discussant, too much. I'm only a learner. But in any case, I'm here to remember you that there is the primary care point of view of this. It would be preferable that a child would arrive to the emergency room well prepared. If something happens in an ambulatory practice, you must have something to do. You must know what to do. For example, 1 week ago, a dear child that I know from when he was born had accidentally an anaphylaxis in my practice because he is allergic. He has anaphylaxis to almonds, and he didn't know that there was a little cookie in my practice. Not with almonds, but evidently with. Within 20 minutes, he had breathless, difficult to breathe and roughly breathe, and edema of the eyes, and then urticaria, but within few minutes. And I was in my practice visiting another child, a well child, and the mother, please doctor, I have a problem with my child. I was waiting in the waiting room, but so he is. What I can do, what I could do in that situation. This is important to have, or what you need. Firstly, adrenaline. Secondly, something to inflate. I don't remember the name in English, but I have ambu.
Yes.
And that's it. And if it's possible, something to open a venous access. Well, I had it, but it's not so normal, it's not so simple, and I was alone. This is a danger, because if you are alone in this way, there is no possibility to do what he said. I'm concentrated on the child. Other people must do something else. It happened, all succeeded, the adrenaline worked very well, and no pain, no problems at all, no harm, and so on. It was a lucky situation, but the child remained in my practice for 4 hours to wait for eventually second time of the anaphylaxis that you well know. Well, this is what I mean. Primary, secondary, tertiary care must work together. And at every level, you must know very well which is your work, which is your task. And possibly, please, work together. That's all. Thank you for your wonderful presentation.
Deborah, are we able to, am I still able to share? Yeah. Fine. That would be great. What questions do you have from the case either from the case or other questions? The question is brewing. A few questions are brewing. I'm hearing one here. Give a moment. Speak loudly so they can hear you.
In the gynecology case, okay, so the first day of life of the baby, when
Yes.
just born, they have if we have the time to make some medication like midazolam or other things, or we have to take the newborn.
So the newly born in the delivery room or emergency department, just a crash delivery, oftentimes if they're floppy, if they're not responsive, you can just intubate. But if they're moving, etc., we recommend that you still use the medications. Many neonatologists will not use much medication at all. They use routine, but oftentimes that leads to less successful first pass success and more trauma to the airway. So you have to use your judgment as to whether the baby is flaccid and it needs an immediate intubation without pausing for the medications, or it's a little bit older, you have time and you can send it away.
What do you do with the newborn? Like, what do you do? Like, you just administer rocuronium or?
No, I personally, I won't say never, but almost never will just give a paralytic, because you have no idea how awake the person is.
I mean, in the newborn, in a floppy newborn.
Floppy newborn, just the two.
Okay.
Freshly born, flaccid, APGARs 1 and 2, just putting it through. But if the patient is moving, etc., then I would not give paralytic alone. You have to give something plus the paralytic.
Also for the neonatology, for the newborn is available midazolam.
Less frequently used. Much less frequently used. Midazolam. The newborn is kind of a different.
Yeah, different thing.
It's bag mask ventilation, stimulation, suction is very successful with this one. Almost never. What's with this patient? This patient here, 12 years old, respiratory distress, becomes lightheaded, dizzy. Is that a word here? Yes. When lying flat, and gets a lot of respiratory distress. When sits up and leans forward, seems to be pretty good, fine. Every time he lies flat, respiratory distress. Turns on his left side, better. What do you think? Is this a respiratory emergency or not?
A respiratory distress, which depends on position, may also be something of cardiac stuff, like cardiac problems, maybe. Or
But why would a cardiac problem go away when he's set up?
because maybe
He has distended neck veins. When he lies down, his neck veins distend.
yeah, because the gravity brings down the blood, and then there is no blood accumulation in the upper ward. I don't know how to explain that, like orthopnea, no, maybe.
Yeah. Pretty dramatic. We get an X-ray, and he has a huge mediastinum. So a mediastinal mass can be very positional, and it's an emergency. If the pediatrician sends the child in for a CAT scan or some imaging, don't sedate that patient. Because if you sedate that patient and lay them on their back, they will arrest. Because it can compress the airway and it can compress the vena cava. So the blood return is gone. So this can be a pretty normal looking respiratory emergency to have a large mediastinal mass, leukemia, something going on. How about, so we have a 2-year-old with known epilepsy on anti-epileptic drugs who has a prolonged seizure. His mother gives him some rectal Valium and brings him to either the office or to the emergency department. You put some oxygen on because he looks pale and is not breathing regularly. How do you support this child? What kinds of things are you thinking about and anticipating?
Maybe respiratory depression because of benzodiazepines.
It could be because of the benzodiazepines.
Or because of the status.
Or because of the seizure. Or he could have status epilepticus underneath that's not tonic-clonic. He could still be seizing, or he could have gotten a lot of Valium. It's hard to know. Does it matter to you at this moment? It matters a little because you don't want him to keep on seizing if he's got status epilepticus. But the management of the respiratory failure is the same. It's the same. Give oxygen. If oxygen is not enough, assist the breathing. What's the most likely reason this child is desaturating? It's most likely the tongue. It's most likely that he is
Positioning.
So positioning in these children, suction is very critical. So don't forget that. Even if you're thinking about the seizure, don't forget about the airway and the airway obstruction. And this is where the mnemonic, so suction, oxygen, airway, positioning, this is where this is really helpful because in the moment, it's easy to forget any one of the elements. Jacopo, any comments? No, in the emergency department, what are the most frequent problems you see during the treatment of respiratory emergencies? For instance, for me, I think this silly blood pressure cuff on the pulse ox is one that comes up all the time. I think that people having the oxygen become disconnected without people knowing is another one. What else do you see?
Probably the problem is that when you have a respiratory problem, emergency room, you need a lot of things to do and to have.
At once. You want them all at once.
At once.
And I am alone, and probably we are not well organized to have all that we need. I think that in our emergency room, in a low resources emergency room, we need to have a well-organized pediatric staff with an emergency backpack, for example, where you have all the necessary in the backpack.
Organized.
Well organized. Because when we have a different turn, when we are on call, we work in team with different staff of nurse, for example. Normally, that nurse work with adult patient, and only one over, 30, 40 patient are a pediatric emergency. 40 adult, one, or 100 adult, one pediatric. So when we ask, please give me something to make suction, for example, they have only the sucks for adults, okay? And, or for example, give me a pulse oximeter. Very simple pulse oximeter. We have only the adult sides. So when you have a newborn or a baby of 6 months, the adult don't work. So I think primary is organization, and the second is simplify. For example, she says a good bag mask, epinephrine, I don't remember, but you have is not important in the first minutes of emergency to have the possibility to intube the patient, no? But if you have a good organization of simple things, bag mask, pediatric saturimeter, oximeter, pediatric oximeter, and drugs also, you can have a better emergency pediatric experience that I think this is important. Better than know the big knowledge, big okay.
So it's the basic things and
Basic things.
prioritizing the most important basic things to support the child until help arrives.
And we don't have the ability to have a checklist, because when I use a backpack, after the use, I don't recheck. So when use Carolina use my back check after me, found the things are mixed. So I think this is
So at
our
our
mentality. I
hospital,
don't
we
know.
have a respiratory pad that we have, but we have a, like the code card, we have a clip on it. So after it's used, it's replaced, a new one is stocked, this one is filled up, and then a clip is put on it, so you know everything is in it, and it's not missing.
If it is a new one or just used. It's impossible to use again part just used. You have to use the new one always.
Exactly. You have to have some extras, so you can replace and replenish, and then put it back.
Yes, of course.
So in a sentence, it's important to know how to perform a respiratory emergency, but it's important that that respiratory emergency is well organized before it happens.
Yes, anticipate and
Anticipate
prioritize.
and prioritize.
And that's why the last slide I have is just do the right things, but what's covered up is and do the things right. Do the few
You can
things.
hide it. If you don't hide, you can cancel.
Here we go. Thank you. So it's but it's and do the things right, meaning there are a few things you have to do right away. Make sure those get done right. Practice that, not just in theory, but by practice.
Okay.
In your experience, does to expect the pharynx with tongue depressure induce laryngospasm if you suspect epiglottic? Because
Yes, but we don't test it very much
Yeah.
because if we suspect
we
epiglottitis,
don't do,
we don't do
just
it.
don't do. Okay.
But truthfully, nowadays,
Yes, because it's the epiglottic which really.
now it's rarely, for us in the United States, it's a rare event if it's an infectious epiglottitis. More often it's a viral supraglottitis, or it's a mother with a long fingernail.
Yeah.
The baby's choking and she tries to get it out. And instead she scratches the back of the throat and gets the epiglottis.
Oh, really?
Because a lot of people have long nails and they
You're
still
really saying
try to
that
do.
it
they
often
try to
happens.
do-
All the
So-
mothers try to do this.
Yes.
Yes, it's the first try.
Oh my God.
È la prima cosa che provo. Non dobbiamo dare un po' di stare, è la prima.
Okay, I have
Grazie ancora.